Yes, you started.
Good afternoon to everyone present here. I am Faraz from IJCP Group. Welcome all the participants on today's session. Let's welcome today's speaker with great honor, Dr. Ash Sujit Ji, sir. And let me share some of the achievement of sir. Sir has done MBBS, Diploma of National Board in Obstetrics and Gynecology, and Fellowship in Minimum Access Surgery, World Association of Laparoscopic Surgeon, WALS, Diploma in Gynecological Endoscopy from Caen University, Germany, IRCAD from France, and he is Senior Consultant in Gynecology and Obstetric Department of PD Hinduja Hospital, Mumbai. And today he is going to speak on a topic cervical cancer and understanding it better. By taking not much time, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Thank you, Farah. Good afternoon. Today we'll be talking about cervical cancers. Quick note, this is a very used topic, so I tried to make it as concise as possible. And maybe I'll rush through certain slides also as we go on with the details. So we all know that it is one of the commonest cancers currently occurring in India also. As per the statistics, around 77,000 women die in India every year because of cervical cancer. So yes, that's a huge burden. And if it's not diagnosed very early, then the chances of death is very imminent. The pap smears that we do, which is also effective in picking up even precancerous lesions. Therefore, this is something that has to be recommended. When you know this is the cervix, which is as per the anatomy, this is the mouth of the uterus or the lowermost part of the uterus, where you have the ectocervix and the endocervix. Endocervix is the canal, whereas the outside part is called ectocervix. And in between, you have the transitional zone, which is the area from where most of the cancers begin. Cervical cancers are mainly two types. You have a squamous cell carcinoma, which is the most common, which develops in the ectocervix. And you have the adenocarcinoma, which is less common, and it is usually seen in the endocervix, which involves the glandular cells. There is a precancerous lesion, which is called a cervical dysplasia, which is that some cervical cells are abnormal, but these are not cancerous. They can be precancerous. However, with time, if it's not detected or if it progresses, this can progress to malignancy. When you come across these cells, and you can decide whether you need to continue pap smears every yearly or whether you want to do it every 3 years, or you can ask for even the HPV DNA load. So you can confirm whether the HPV cells are affected or the ones which are involved. So depending upon this, you have three classifications also by Bethesda. You have the CIN1, CIN2, and the CIN3. After this, you can move on to the malignancy reports as we do it, or as we see it on our pap smear reporting also. These cancers are majorly caused because of HPV. This is what we all know about. HPV are something which is ubiquitous. So you need to understand that HPV is present in every one of us. But depending upon body's immunity or the strains that we come across, some strains we might not be immune to, and that is what can multiply and lead to cancers. As per the reports and as per the studies, around 90 to 95% of HPV virus is actually killed by the body. So if you have very good immune system, the HPV is actually killed in the body, and you might not land up with HPV related changes. But in those few who have a decreased immunity or who have a lot of exposure to HPV because of different reasons or because of hygiene issues, in these the HPV might multiply and lead to changes. We all know that there are different strains of HPV. There are 80 strains of HPV. Of that, 6 and 11, the strain number 6 and 11 are something which can lead to genital warts, which is very common. And these are something which are not associated with cervical cancer. The other strains can lead to cancers, which include 16, 18, 31, 33, 35, 51, 41, 43. All these can lead to cervical cancers. Nowadays, we have vaccines which have been showing efficacy against such cancers. You have different strain-related vaccines, which are either 4 or 9 strains. So depending upon which vaccine you're using, you get around 60 to 90% safety against these cancers. Smoking again one of the etiologies which can be related to HPV. It is regarded as a compounding effect rather than directly affecting the cells leading to cervical cancer. Immune system are the major probability causes where you have poor immune system leading to an increased risk. Also, there is a thought that contraceptive pill users land up with a higher risk of cervical cancer as compared to those who do not, those who are using some different modality of contraception. Well, this is something which has to be some related to behavioral, where if someone is using a contraceptive pill, then they stay away from barrier method of contraception, and that can lead to increased risk of any STIs. The symptoms can include postcoital bleeding or bleeding per vaginal, which is irregular or continuous. You might have vaginal discharge, which is offensive, foul smelling, fishy like odor. You might have pelvic pain, or most of the times there are no symptoms at all, and you can directly detect whether patient is anorexic or the kidney stop producing urine. That is eventually the end stage of cervical cancers. When you examine a patient, depending upon what or which stage you're examining, you might find a patient who is cachexic, anemic, there might be edema of the legs or lymphadenopathy. You might have an ulcerative growth or a fungative growth, and this growth bleeds on touch. So always be very careful when you're taking a biopsy of cervical growth, because if it's a cancer, it will bleed to touch and the patient can have massive blood loss. So keep something handy where you can coagulate or cauterize the bleeding with different modalities. A bimanual examination can show an induration or a hard barrel-shaped structure because of the growth which is there. The extent of the growth can reach out to vagina and to the sides and can also be felt through anterior fornices also. Always do a PR examination whenever you're considering any malignancy, so as to find out the POD or the rectal involvement, and involvement to lateral pelvic wall also has to be confirmed. The differential diagnosis can be depending upon what you're examining and which age group. There might be tuberculosis or syphilitic ulcers. There might be a fibroid polyp which can be bleeding on touch, or it can be an incomplete abortion also. So whenever you are coming across such scenarios, there's a pre-treatment evaluation that you need to do. So take a proper history, do a proper physical examination, and ask for blood investigations. Then consider staging or histopathology. There are usually no markers for any malignancy for cervical cancer. So yes, that is something which is not valid. But these are certain investigations which are always recommended when you're considering cervical cancers. So you do a proper inspection, palpation. You can do a colposcopy wherein you have different kinds of solutions which are used. So I'll just quickly tell you the steps of colposcopy. You have a video colposcope, or you can just do it under visual examination also. Examine the cervix first after cleaning it with saline. Then you look out for any abnormal vasculature, which is usually seen under green light. And then you apply acetic acid for a minute. And if you see any acid-white areas, which indicate that the cells are multiplying very rapidly, and then after that, you apply Lugol's iodine for around 20 seconds. And then if the acid-white areas turns Lugol light areas, then that area is suspicious. So you take out biopsy from such areas and send it for testing to find out any evidence of malignancy. You can always do an endocervical curettage also if you're suspecting anything which is related to the endocervix. Hysteroscopy, proctoscopy, depending upon the extent. The barium enema or IV intravenous urography can also be advised. Chest X-ray and conization as regards to physical examination can also be done. These are some of the tests that we've already discussed about. You have optional investigations where you can do a lymphangiography or a venography to look out for lymph node spread. You can do a laparoscopy also. USG, CT, MRI can also be done. And these are depending upon what you have an availability of. FNAC of the detected lymph node can be done, but then that is also if you find that there's any lymph node spread which is involving. Complications, the most common reason for death in cervical cancer is because of renal failure, where you have frequent attacks of ureteric pain, pyelonephritis due to hydronephrosis. There might be pyometra, especially in cases of endocervical variety. Because of the extent of the cervical cancer, you might land up with psychovaginal fistula or rectovaginal fistulas. Rectum can be involved either through uterosacral ligament or through rectovaginal septum spread. So the causes of death can be because of hemorrhage, because of the growth becoming very high, or that can bleed, or because of the malignancy itself leading to anemia and ill health. There might be localized or generalized peritonitis, which can be leading to sepsis. Cachexia is because of any malignancy which can affect the general metabolism. Metastasis to distant organs, especially to lungs, can also be fatal. And uremia, which I already told you about, that this is one of the major causes of deaths involving cervical cancers. So when you need to stage, you need to find out what's the prognosis of the patient, how to formulate the line of treatment, and to compare the result to another. But then it's very difficult because we don't usually get an access of lymph node in the prognosis, and it's difficult to manage or differentiate inflammatory and malignant intubations at some times, and then you might be over treating an inflammatory cause, considering that it might be malignancy. So you have the following staging procedures are allowed by FIGO, which we have already discussed about, considering the investigations which are or the procedures that you can be doing. So coming to the staging, you have cervical carcinoma in situ, stage 1A, 1B, which also has subsets depending upon the amount of spread which happens in. So this I'll quickly rush through. As you can see, this is something which is available very easily, and the major part of my discussion is covered. So I'll be rushing through these things so that we don't waste a lot of time. I have around 70 odd slides for this. So you have microinvasive carcinoma and invasive clinically visible carcinoma, depending upon the size. So you have anything which is less than 3 millimeters or 3 to 5 millimeters. And an invasive clinically visible is around a centimeter size, which can range from something which is between 1 to 4 centimeters or more than 4 centimeters. Then you have stage 2, which is beyond the cervix but not to the pelvic wall, where you have involvement of the upper 1/2 of the vagina or parametrial involvement, which can be seen. Then the stage 3 comes in, which extends to the posterior surfaces or the lower 1/3 of vagina or the hydronephrosis, which can involve stage 3A or stage 3B, and eventually stage 4, where it involves the bladder or the rectal mucosa, or which spreads outside the true pelvis. What you need to understand is this malignancy is so difficult to treat that you don't have surgery options available after stage 2, 3, 4, for stage 2, 3, 4. So therefore, it's important to predict and to analyze and to find out or investigate earlier so that you can reduce the spread and you can curb the disease at the earliest. So stage 1, the carcinoma is strictly confined to the cervix. Depending upon what we saw, there is stage 1A, 1B, and all the details which are given in here. And stage 2 is which is extends beyond the cervix but has not extended up to the pelvic wall or may not involve the extent of the vagina. Stage 2 A also has 2A and 2B. Stage 3 is something which is extended into the pelvic wall, and then it can involve, and this can lead to obstruction of the ureter and can lead to non-functioning kidney also. And stage 4, which involves the beyond the true pelvis, which can involve the rectum also, or can spread to distant organs. The planning of treatment modality is you have to firstly identify the carcinoma as early as possible rather than detecting at a later stage, which is the CIN staging also will be very helpful. Stage 2, 1A requires a histologically based therapy, which is depending upon the reproductive age group of the patient, the family completion, and how much the spread is involved. So you can do either a conization for the patient or you can do a hysterectomy, depending upon if or not the family is completed or not. Radiotherapy can be employed if you find that there is an extent which is there, which is involving the lateral walls also. Stage 1B is also radical hysterectomy with pelvic lymphadenectomy. If the glands are positive, then you also think about radiation in such cases. So as you can see, as early as stage 1B or 1A, we are considering hysterectomy because that's the only method of treatment that we can do in very initial stages where you have a CIN, or if the family is not complete, you can opt for conization or ablation, but then eventually hysterectomy is something which is recommended. Radiation is done in most of the cases. Chemo is done only when you come across adenocarcinoma. Otherwise, squamous cell requires your radiotherapy. So stage 0 or carcinoma in situ, the treatment option should be conization, laser surgery, or hysterectomy. Stage one, it's always a hysterectomy with conization in very early cases where the family is not completed. But you have to be very careful in such situations. Whenever you're doing a conization, always remember that you need to do an encirclage or make sure that the risk of preterm deliveries will be higher. So be a little careful in such conditions. Radiation therapy is also recommended in certain cases of stage one. Stage 2, 1B will have a radical hysterectomy with lymph node dissection, with or without chemotherapy, depending upon where the cervix is involved. Stage 2A, it's spread around. So, therefore, in such situations, you will definitely begin with or require radiation therapy along with your surgical aspect of radical hysterectomy. Stage 2, the cancer has spread to nearby areas and there's cancer which is around the cervix. So, therefore, the treatment is majorly radiation therapy and not hysterectomy. So you understand that when it's already stage 2B, the disease has progressed so much that even a hysterectomy won't be helpful in such scenarios. Therefore, as stage 2B onwards, you have to always think about radiation therapy and chemotherapy if required. And you have to keep a check about the involvement of the ureters in all the cases and wherever the cancer has metastasized. Recurrence has also been noted after the treatment is done. And whenever there's recurrence in such scenarios, radiotherapy combined with chemotherapy can be helpful in reducing the side effects. Side effects can occur with most cancer treatment, and it's very difficult to destroy the cancer cells of cervical cancer without affecting the tissue. So surgeries can be conization or LEEP. That is something which we do very commonly out here. So whenever I have any inflammation where I see a CIN situation, so before doing a conization, you can also think of doing a loop electrosurgical excision procedure, wherein you have a small loop which can have a monopolar current, and you can just take shavings of that involved area if you don't want to do a conization. And a laser beam also, if it's available or it's there at your place, you can use a laser beam to burn the areas. The drawback with laser beam is I won't have any tissue left to send for histopathology. Therefore, I prefer the leaf. And conization, yes, in certain cases, we have to do conization, so we ask for it. So indications of surgery when I'm doing a conization, it's a curative procedure at stages 1B or 2A when the growth is less than 5 centimeters. And in a young and surgically fit candidate where I have to think of a pregnancy also. You have vagina which is left over. Whenever you're thinking of any surgery, there's these things which are making sure that the patient has a good reproductive life even after, or at least a sexual life even after doing a surgery. You don't do such heroics, or you just make sure that if the patient has a bad immune system, if any other comorbidities which are associated, be a little wiser when you're choosing the surgery that you want to do it. I think from here on, it's just a repetition of all the surgeries in detail. So I guess this is something which you will all be following different types of hysterectomies and any other malignancies also depending upon the extent. So I'm not going into detail for that. Radiation therapy is what you know as that we use a high energy X-rays to kill cancer cells and shrink the tumor. There are side effects where the patient can have reactions to the radiotherapy and can lead to early menopause and problems with urination also, because this is something which is very closely connected or related to the bladder. So this is one aspect that you have to explain to the patient also. Chemotherapy generally given in stage 4, but you can give it as early depending upon what your coming across, and this also has certain side effects, but the major ones which the patient come across is the hair loss which happens or the ulcers around the mouth and the vagina. You need to explain the patient about this. This is the survival rate. So as you see, stage 1 has a very good survival rate, but as it goes down to stage 3, stage 4, the survival rate is very less. So you do your pre-treatment evaluation properly, continue doing your pap smears, and then the idea of the recent thing is that you have pap smears which are there. I'll quickly run through that before we end the session. So pap smears begin at as early as the age of 21 if you need to do for any woman who's sexually active. From 21, it's done once every 3 years till the age of 65, provided that the lady has a uterus and it's not there's no hysterectomy which is done for any cervical malignancy. And you do it every 3 years, which can go on if you have the facility and if there's a possibility after the age of 30, you can also add HPV DNA testing, which can be done. So from the 3-year validity, the HPV DNA and the pap smear done together, which is called the co-test, that increases the validity of that pap smear to around 5 years. And also it helps us to pick up the virus. If there is any HPV positive scenario that you notice, along with any changes in the cervix, then you can opt for a colposcopy. If the cervix is normal and if you find that there is some HPV positive situation that you come across, in such situations, you can just repeat the pap smear again after a year to keep a check on the HPV. Like we discussed initially, most of the HPVs are killed by the body, so you don't have land up with a lot of issues. But in certain scenarios, that the HPV might progress and can lead to changes. So therefore, you need to keep a tab of all these situations. Vaccines are available, whichever vaccine you prefer. The strain 4, strain 2, strain 9, whichever thing you are preferring, you can go ahead with it. The vaccines have been proven to be safe. They are here for the last almost 16, 17 years, and they do not affect any fertility or do not affect the menstrual cycle. And it's given in the age group of 9 till the age group of 45. Depending upon the age group, you decide the number of doses, whether you require 2 doses or 3 doses, and they are bound to be effective. And if you come across any patient of CIN or cervical cancers, it is wiser to manage it as early as possible rather than waiting over it, and the patient will be better. As you can see, the stage 1 and stage 2 have very good 5-year survival as compared to stage 3 and stage 4. So with that, I guess we'll end the discussion for today. The rest are just the discussion that we've had depending upon what we've discussed. So thank you.
Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one. I
Thank
definitely
you.
think this session knowledge is going to help all the participants during the practice. Sir, I can see, sir, we have received some questions from the participants. If you allow, with all your permission, shall we take these questions? Yes, sir. The first question is that, like, how do you monitor patient for reoccurrence after completing treatment for cervical cancer?
Again, you continue to make cervical cancer. If the patient has a vascular thing, you can check for that. Look out for symptoms, ask for sonography, or you can ask for different imaging modalities where it can be done. And always tell the patient to look out for symptoms that are important, the precancerous symptoms, what we were discussing about. Ask the patient to look out for that. That is how we'll be monitoring such patients of post-cervical cancers.
Thank you so much, sir, for sharing your insight on this question, sir. Moving forward, there is another question from Dr. Agarwal Mahapratab, and he's asking, are there any promising advancement or emerging therapies in the field of cervical treatments?
So we have the early, whenever you have early detection. So the emerging therapy, I would say that pap smear with the HPV testing is one of the things that I consider that should be used. The West have been using it, but in most of the interiors or even in Bombay, like a city like Bombay, this is not something which is commonly done. That can be considered an emerging thing. When you need to use a therapy, the laser or the cryo thing is something which is beneficial and it doesn't use a lot of current. The colposcopy, we have a video colposcope, so where I can just take the entire video of the colposcopy done, which can help me explain the patient also better. And in that same setting, I can do a leap or a cryo or a laser ablation, which can be helpful. And it's just an OPD procedure, which will be giving me quicker outcomes also. Apart from that, the surgery remains surgery. The radiation has been the same. There's no major changes in the radiation therapy or the chemotherapy. But then the awareness regarding cervical cancer and how much it affects or how much burden it causes is something which is being spreading nowadays with the vaccine being implemented with the health minister also. So I guess that is one of the leaps that we have taken ahead when it comes to cervical cancers.
Thank you so much, sir, for answering this question, sir. There are some more questions. I will be taking another question, sir.
Yeah.
The question is from Anika Sarfaraz from Kolkata. She is a doctor and she is asking, what are the current standard treatment modalities for cervical cancer and how they are selected for individual patients?
So you have to find out the staging as per the PIGO. You have a staging which is there, which I discussed with you. most of the time you have to find out, see, there are two things that you have to find out: the staging of the cancer and if the family is completed or not. If it's a very early cancer with a CIN, or if you have a carcinoma stage 1A or something, then you can opt for a LEAP or a conization, whichever is applicable. If it is something which is more than a stage 1B, in such situations, you have to opt for a hysterectomy along with radio or chemotherapy. The good thing that you can do nowadays with the advent of this is that before doing the chemotherapy or a radiotherapy, you can actually stimulate the ovaries and collect the eggs from the patient, and that can be used at egg freezing. And then surrogacy, the possibility of surrogacy is possible in such scenarios. So that's the one thing that we can think about. Otherwise, there's no major change which has happened over years when it comes to the treatment modality or the surgical modality for treating a cervical cancer. Next,
Thank you so
please.
much once again, sir, for sharing your insight. Moving forward, one other question is from Dr. Asad Tanveer, and he is asking what are the common signs and symptoms of cervical cancer and how can they be differentiated from being condition?
So the most common symptom of cervical cancer is post-coital or post-sex spotting or bleeding that can happen, which can be when you have a growth or when you have slight ulcerations. Whenever you find spotting or bleeding which happens in, always get a pap smear done. That's the only way you can find out if there is any cervical cancer, or if it's just done to rule out basic inflammation or infection, that is also fine. It helps me to prevent something as dangerous as cervical cancer. Otherwise, most of the time, cervical cancer is silent. You don't have any complaints if there's no growth which is there, and you can directly find out when there's a pyometra or there's a hydronephrosis blocking the urine thing and you have anuria, or if the patient has severe anemia. So when you read the books, also when you read the literature, the common presenting symptoms are actually the end stage symptoms where you have anemia or hydronephrosis, anuria, or if there is a pyometra which is there. So the importance of pap smear. Again, I'm getting into that pap smear is something which has to be done mandatory. We make it a mandatory rule for any patient who comes to my OPD. If she's never got a pap smear done, make sure that she gets the pap smear done, or at least she's aware about the pap smear test which is available.
Thank you so much, sir, for you sharing your expertise in this question, sir. We will be taking one last question, sir. I think
Sure.
this is a very important question from Dr. Nisad, and she is also from Kolkata, and she is asking how effective is the HPV vaccine in preventing cervical cancer, and what age groups are recommended for vaccination?
So as everyone knows, we have different varieties of cervical cancer vaccines. We have something which has two strains. I'm not taking the name of the brands, but I guess you all are wise enough. We have a two strain brand which is there. We have a brand which has four strains, and we have a brand which has nine strains. So we have to understand that depending upon the number of strains the vaccine is covering, the protection is better. The protection can range from the 50% till 90% plus, depending upon at what age group you're administering. Currently, just a couple of weeks back, the government of India has made it a rule that every girl between the age group of 9 till the age group of 14 should get vaccinated with a cervical cancer vaccine, depending upon whichever vaccine you choose it. So anyone who's less than 15, and we started as early as the age of 9, even when she's not got her periods, or even if anyone is not sexually active, you have to give the vaccine. And anyone less than 15, you require two doses within a span of 6 months. So you get the first dose, and after 6 months, you get the second dose, and that girl gets lifelong protection. And again, I'm reiterating that the vaccine does not affect the periods or does not lead to any fertility issues. Anyone who's more than 15 till the age group of 45 can take all the vaccine. Even if she's had sex and even if there's a childbirth that has happened, she can still take the vaccine. In such situations, there are three doses which are given. The first dose, after 2 months, the second dose, and after 6 months from the first one, you get the third dose. And in such situations, you get a lifelong protection. Anyone who's missed out on the last dose can also take the vaccine whenever it's possible. It's important to be vaccinated and completing the schedule rather than missing out on them. And a regular pap smear has to still continue, because every time the thing is, if someone tells me that I've got vaccinated, do I need the pap smear to happen again? The answer is yes, because the Vaccine gives you protection only against 2, 4, or 9 strains. HPV has around 80 odd strains, so you need to be protected, or we can't determine if the other strains can cause cancer. So therefore, your pap smears will continue. So I guess with that, I guess the entire answer is done.
Thank you so much, sir. I hope you are able to solve all the queries related to this topic, sir. As I can see, sir, Dr. Anika Sarfaraz has written, wonderful session, and thanks for answering my question and making my things easier.
Thank
I
you.
hope, yeah, I think she is really enjoyed this session, sir. As I
Thank you.
can see, sir, there is no more question, sir. With all your permission, shall we conclude this session for today?
Sure, we'll conclude the session. Thank you everyone for listening and hope you practice whatever we've discussed today.
Thank you so much, and hope to see you again with different topic